Hi, I want to welcome everyone to the session of Sirens, Racial Health Equity and Social Care National Research Meeting 2022 titled Differential Impacts of Social Care Interventions, Part 1. My name is Janeth Sanchez and I'm a Program Director at the National Cancer Institute, and I am your moderator for this session. Joining me today as a discussant is Ms. Tia Francis, who is an expert by experience and will be sharing her unique perspectives on the topics presented today. Before moving on to our presentations, I want to go over a couple logistical items. First, I want to remind everyone that there are several ways to participate in this session. But first, reminding everybody that we are recording and slides will become available after the meeting. You can participate in the session by entering your questions and comments in the chat box on the right-hand side of your screen. We also encourage you to use emojis if you were able to attend the panel session this morning earlier. You can go ahead and share your reactions to what's being presented throughout the presentations using those emojis. While we do want you to stay muted during the presentations, there will be an opportunity to unmute and ask questions later on in the session. But we also, like I mentioned, encourage you to enter your questions and comments in the chat box. For those of you who are on social media, we do have a Twitter handle for the meeting, and we encourage you to go ahead and tweet your thoughts about the meeting and also about the session using the Twitter handle hashtag Siren Racial Equity, and also tag at Siren_UCSF. If you have any questions or are having issues with Zoom, please feel free to email siren@ucsf.edu for assistance. And finally, just a quick reminder, I know we've already mentioned this before, but want to remind everybody that this meeting is a safe space to share your thoughts, research ideas, and lived experiences in a manner that is judgment-free, empathetic, respectful, inclusive, mindful, and also acknowledging our differences, our privileges, and also our unique experiences. And with that, I'd like to now introduce our speakers for today. Dr. Don Wiest, who serves as a Director of Research and Evaluation at the Camden Coalition. Rachel Zucker, who is Project Manager at Kaiser Permanente, Colorado's Institute for Health Research, and Dr. Cristina Huebner Torres, who is Chief Research and Population Health Officer at Caring Health Center. Thank you all for being here today. And now, Dr. Wiest, please take it away.
Hi, everybody. Thank you so much for joining. Might take me a couple seconds here to get my slides up. Look good? All right, great. Again, thank you so much for joining. I'm delighted to be here with you all. Today, I want to share some information about a collaborative project that we're working on in Camden, New Jersey, and also want to share some of the preliminary data related to our research questions. So our project that I'm going to describe today is a collaboration between the Camden Coalition Community Advisory Committee, Rutgers Camden University, Rowan University, South Jersey Institute for Population Health, and the Camden Coalition data team. The South Jersey Institute for Population Health is the funder of our project, and the Institute was launched in 2018 with support from the Robert Woods Johnson Foundation to advance collaborative research projects aimed at improving health and health equity in Southern New Jersey. The project developed by the Camden Coalition and our research partners was one of 10 to receive funding last year through the Institute's inaugural funding cycle. So as part of this project, we're building a data set to share with the Institute that will be freely available to community-based groups, policymakers, and researchers to use as a foundation for advancing health and health equity in Southern New Jersey. The data set that we're building will ultimately combine individual level health and social needs data with community level socioeconomic data that's drawn from a variety of sources. Throughout the project, we're engaging with the Camden Coalition Community Advisory Committee for input into our research questions, analysis, and dissemination. The committee includes residents of the city of Camden and surrounding areas, many of whom are individuals with complex health and social needs who were participants in the Camden Coalition's care management programs. Today, I'm focusing on early data related to a small subset of research questions about the impact of social needs screening and navigation in South New Jersey. The Camden Coalition was one of 28 hubs to launch and test the Centers for Medicare and Medicaid Services Accountable Health Communities model. From October 2017 to May 22, 35,000 Medicare and Medicaid beneficiaries residing in 3 South New Jersey counties were screened for health-related social needs related to housing, food, transportation, utilities, and personal safety. 21% of these beneficiaries were eligible for social needs navigation, meaning that they screened positive for at least one social need, and they indicated that they visited an emergency department in the area 2 or more times in the year prior to screening. Now, for those of you who may not be as familiar with the Accountable Health Communities model, CMS launched the model to test the hypothesis that addressing health-related social needs in the community would lead to better health outcomes and lower rates of preventable hospital use. The data set we're building through our project will enable to test, it'll allow us to test our own hypotheses about the impact of social needs screening and navigation in the context of vastly unequal communities. Many of the communities in South New Jersey continue to bear the scars of explicitly racist policies and practices, such as those related to housing, education, employment, and research distribution. One of the most prominent questions raised through our engagement with the Community Advisory Committee pertained to the effectiveness of our social needs navigation program in places without adequate community resources to address social needs or to support a person's health and well-being over the long term. Many members explicitly mentioned racism, not only in terms of their personal interactions with providers and social service agencies, but also related to the conditions of and opportunities available within their communities. Today, I want to share some of the very preliminary data related to 3 of the project's hypotheses, and hopefully all of us can reflect on how structural racism may influence the outcomes of initiatives such as Accountable Health Communities. So briefly, the hypotheses that I'm going to present some initial data for are: first, unmet health-related social needs are more prevalent in places shaped by structural racism. And in this project, we operationalize structural racism using Brown and Homan's definition of structural racism as a multifaceted, interconnected, and institutionalized system of relational subordination for people of color and superordination for whites that is observable in manifest concrete racial inequalities and life chances. The second hypothesis is that social needs are less likely to be resolved for residents of places shaped by structural racism. And third, in places shaped by structural racism, differential outcomes are evident for Black residents compared to white residents. Today, I'll share some of our descriptive analyses that assess the prevalence of social needs and social needs navigation outcomes for Black and white non-Hispanic residents of the 3 counties. Our full analysis will incorporate all residents, but for today, I'm sharing results for a smaller subset. And for this initial pass of the data, we created 3 zip code categories defined by the percentage of population that is Black that I'll talk about in a bit. In the words of Andre Perry, who's a senior fellow at the Brookings Institute and a scholar in residence at American University, housing discrimination and zip codes have been used to impose bad schools, policing, and healthcare. A few miles can cost Black people more than 20 years of life expectancy. Place matters. Racist policies strongly influence the concentration of Black people in cities and towns, and we should strive to eliminate those inherent biases and structural inequities. But we should not assume that racism is the main ingredient in the social glue that bonds Black folk. Now to the data. This chart shows the breakdown of where residents were screened by race and by zip code grouping. Zip codes were grouped into low, where 25% or fewer of the residents are Black, mid, where 25% to 40% of the residents are Black, and high, where more than 40% of the residents are Black. Social needs screenings took place in 8 hospital emergency departments and 32 ambulatory care offices across the 3 counties, though predominantly screenings took place in Camden County. 45% of the screenings occurred in emergency departments and 55% took place in ambulatory care settings. The table shows differences in where people were screened. It's notable that in zip codes with lower proportions of Black residents, the percentage of Black residents screened in emergency departments was significantly higher than the percentage of white residents, 50% versus 33%, which may point to a disparity in access to healthcare options in such contexts. And as we move across the table to zip code groups with higher percentage shares of Black residents, the differences between the two groups of residents even out. This table shows the median home value, median household income, and population density for the three zip code groups, underscoring the strength of the relationship between race composition and areas, race composition of areas and objective socioeconomic status. We move from zip code group with lower percentage of Black residents to a zip code group with a relatively higher percentages. Property values and household income declines by 59%. And again, one of the reasons that I'm talking about this is to start thinking about how challenging it is to untangle these different characteristics and structural inequities that we see in the data, that very tight relationship between socioeconomic status and history of racist policies and practices. It just, underscores that this relationship is so evident in the data and how difficult it will be as we move through the data into higher levels of analysis to sort of untangle these differential effects. This chart on the left, this is moving into looking at differences in social need reporting as well as navigation. The chart on the left shows the percentage of residents reporting at least one social need by race and zip code group. The data shows significantly higher proportion of Black than white residents reporting a social need in the zip code group with the lowest proportions of Black residents, roughly 60% compared to 40%. The gap in social need reporting among residents narrows as we move across the zip code groups, with equal proportions reporting a social need in zip codes with higher proportions of Black residents as the percentage of white residents with a social need increases. Now turning to the chart on the right, showing percentages of residents eligible for navigation services. Of the 10,127 residents who screened positive for a social need, 55% of them were eligible for telephonic navigation. And again, just to reiterate what that means that these individuals screened positive for at least one social need and had reported 2 or more emergency department visits in the past year. They are considered quote unquote high risk. We see a similar pattern here as we saw in the chart on the left, with a higher rate of Black residents eligible for navigation compared to white residents, until we get to the zip code group with a higher proportion of Black residents corresponding to areas with lower objective socioeconomic status as measured by median home value and median household income. Finally, turning to navigation outcomes. This is a bit tricky to measure with our data because we do not have a reliable closed loop referral system. And I think that's a challenge for a lot of communities across the country who are part of the accountable health communities and who are engaged in other initiatives around social needs screening, referrals, and navigation. For what we did in terms of, coding cases as failed or successful or somewhere in between, our navigators themselves confirmed with the beneficiaries whether the social need that was the object of the navigation case was resolved. And so we ended up with 3 categories of navigation outcomes here. Failed, meaning the beneficiary ultimately opted out of services, even though they opted in at the time of screening, or the navigator was unable to successfully engage the beneficiary. Successful contact meant that the navigator successfully engaged the beneficiary and provided at least a referral, but didn't obtain any evidence that the social need was successfully resolved, and resolved where the navigator was able to confirm with the beneficiary that the need was successfully addressed. So as you can see, the success rate in terms of social need resolution was very low overall, 14%. Just about half of the navigation cases, quote unquote, failed, meaning that, again, the beneficiary either opted out when the navigator reached out to them, or the navigator was never able to establish successful contact in terms of even being able to make a meaningful or relevant referral. we see the chart on the right that shows, again, looking at the zip code groupings and Black residents and white residents within the zip code groupings. We see that a significantly higher proportion of Black residents compared to white residents had successful resolution to navigation cases. And this is especially the case in zip codes with higher shares of Black residents. And we do see that the resolved rate does decline across the zip code groups, but far less so for Black residents compared to white residents, which again raises a lot of questions that as we move deeper into the analysis and bringing other variables into multivariate models, we'll hopefully be able to address. But these are the preliminary findings that we're sharing with our community advisory committee, and would also love to hear your thoughts on. So just before we turn to the next presentation, I wanted to make a few points about our preliminary data analysis and briefly describe our next steps here. Again, we did find that Black residents did have a higher rate of social needs reporting than white residents as hypothesized, but we haven't added measures of structural racism or other important covariates or run our multivariate models. So in our next analysis, we'll also consider type of social need and number of social needs. Again, a very small percentage of social needs cases were resolved through navigation. And we do see differences across communities and across groups based on individual level characteristics. But again, the data here are beginning to uncover a story that needs more digging into and also more input from our community members. And again, just measuring navigation outcomes, which I think is going to be obviously a super important endeavor of the evaluators on the accountable health communities, is difficult, especially without a closed loop referral system. And again, there are many cases, for example, that we identified as unresolved that may have been successfully resolved, but for which we had no evidence in hand. So thank you. I look forward to feedback and questions.
Great. Now we'll move on to Rachel Zucker.
Okay, can folks see my screen?
Yes, we can.
Okay, great. All right. Thanks everyone for joining. My name is Rachel Zucker. I'm a project manager with Kaiser Permanente, Colorado's Institute for Health Research. And today I'll be presenting on the demographic differences in the reach of an initiative in the healthcare setting to screen and refer patients for social needs. And this presentation stems from an evaluation our Partners in Evaluation and Research team has been working on for about the past 3 years. Okay, so our objectives for this session are to discuss the relationship between unmet social needs and healthcare, to introduce Thrive Local, which is a closed loop referral system to address social needs, to share information on need resolution for all types of needs versus our big 4 needs, which when we're talking about those, we'll be discussing housing, food, transportation, and financial needs. We'll discuss how Thrive Local reached our member population and talk about different drop-offs or voltage drops at different steps of the Thrive Local referral process for different demographic groups. And then finally, we'll talk about some of the potential outcomes related to some of the differences we see in the reach of the program. Okay. So social needs are a barrier to health. 1 in 4 Americans report a social need that they say was a barrier to health in the past year. And 97% of survey respondents in 2019 wanted their medical providers to ask about social factors during their care visits. Thrive Local is Kaiser Permanente's program to meet the social health needs of members and patients by connecting them to resources. Basically, it's a technology platform that provides searchable, up-to-date information on a wide range of local community-based organizations, programs, and services, many of which accept electronic referrals from us on the platform. And therefore, we can provide and receive real-time status updates. So we can track where members are receiving the help that they need. And this ability to get these updates forms the closed loop system that we'll discuss. Okay. So once a patient or a member is, shares a social need during a visit, if they consent to receive help through Thrive Local, a care provider can transmit a member's information to Thrive Local by clicking on a Thrive Local button within Epic. The provider can then create one or more referrals to a community-based organization or CBO. The CBO can then accept the referral. They might reject it, for instance, if the member lives in an area where they don't provide services. And if they do accept it, the CBO can then provide updates on the referral until hopefully it moves to closed and resolved status. Although, as we'll discuss, many referrals remain unresolved. Okay, so we're using 3 different data sources to track how folks are moving through the Thrive Local steps of the referral process. The data sources include membership data, referral data from the Unite Us Thrive Local platform, and social needs screening data. Just a few notes on our limitations. This data spans from January 2020 to May 2022. Each region of Kaiser implemented the program at a different time during that period. And then this is a snapshot. Folks may have, progressed further after we took our snapshot, but this just reflects a moment in time for our data. Okay. So not everyone who has a referral started moves through the system successfully. So at this top bar, we'll see those who have at least one Thrive Local referral started. Moving down, we see those who have at least one Thrive Local referral accepted by a CBO. And then this final line is the Thrive Local case being closed and resolved. So for those with any type of need, about 3/4 of individuals have a referral accepted by a CBO, and just under half have a closed loop referral that has been resolved. We're gonna dive into our big 4 needs. So we can see how folks move from the referral again being created to accepted, hopefully closed and resolved at that last bar. Transportation and housing saw the biggest voltage drops in referrals reaching closed status, with each of those reaching about 31% of referrals reaching closed resolved status. Food referrals were the most likely to be successfully closed with about 46%. And we also see that most of our referrals were for food needs. And this may be due to some targeted efforts in regions to refer to a central food-related partner and to use Thrive Local for evaluations of food-related programs. Okay, so next we're gonna look at a slide that has a lot on it. Just to give you a little orientation, at this top bar, we're looking at all members of the Kaiser system. Next up, we're looking at any of those who have a social need indicated in the EHR. And then the final 3 bars are those same, having a Thrive Local referral started, accepted by a CBO, and then hopefully closed and resolved. And so we're looking at how folks progress through the Thrive Local system by a bunch of different demographic characteristics. And on this first slide, we're looking at age. So for members 18 to 64 years of age, we do see a drop in members with social needs, this 59%, making it into having a Thrive Local referral started with 45%. So in other words, fewer 18 to 64-year-olds than we might expect based on the screening are getting a referral started in Thrive Local. We see a relatively small drop, this 45%, making it to having their Thrive Local case closed and resolved, about 42%. And then we see the opposite with members 65 plus. So we see that they are overrepresented in having a need indicated in the EHR, and then that they continue to increase in proportion of Thrive Local referrals started, accepted, and then closed and resolved. So here we're looking at the same funnel except by gender. We do see that females are overrepresented in having a social need indicated in the EHR, as well as having a referral started, accepted, and resolved. However, we see that individuals are moving through the Thrive Local funnel at similar rates regardless of gender. So we're not seeing a notable voltage drop. Okay, next up, looking by insurance type. We do see that individuals on Medicare are overrepresented in having a social need indicated in the EHR compared to our general population. Moving into the Thrive Local system, we see that members using Medicare and Medicaid are overrepresented in having a Thrive Local referral started, accepted, and closed and resolved compared to those with a social need. Okay. We'll dive into race and ethnicity a little bit more. Compared to all KP membership, Hispanic individuals are overrepresented in having a social need indicated in the EHR, 26%, but they're less likely to have at least one Thrive Local referral started with about 17%. So that is, we're seeing that voltage drop or drop off in Hispanic members getting a referral started compared to the proportion with a social need indicated in the EHR. Looking at Asian and Pacific Islander members in this light blue, we also see that they are less likely than the general population to have a social need indicated in the EHR. And then we do see them drop from 10% here to about 6% having a referral started in the Thrive Local system. Looking kind of step by step, we do see some significant differences in race and ethnicity between members who were and were not screened. For instance, in the ever screened group, about 41% of those of that group are white, compared to about 34% of the not screened group. We see that about 27% of the ever screened group is Hispanic, compared to about 23% of the not screened group. And about 14% of the ever screened group are Black members, compared to about 8.7% of the not screened group. There were also some significant differences found between those who were accepted by a CBO versus those who were not accepted. For the ever accepted group, we see about 18% are Hispanic, compared to about 15% of the not accepted group. We see about 44% of the accepted group are white members, compared to about 48% of the not accepted group. And in the ever accepted group, about 25% of that group being Black, compared to 23.4% of the not accepted group. And there were some smaller but still statistically significant differences by race and ethnicity in the groups who had their referrals resolved versus not resolved. So we see both groups are made up of about 44% white members. In the not resolved group, we see about 20% are Hispanic, compared to about 17.5% of the resolved group. And in the not resolved group, about 23% are Black, compared to about 26% of the resolved group. Okay, so overall, we are seeing that there are demographic differences in how people move through Thrive Local. Groups that are overrepresented in having a social need compared to the general population tend to be older, female, non-Hispanic Black, non-Hispanic white, and on Medicare. Groups that are underrepresented in having an on-platform referral started compared to those with a positive social need tend to be 18 to 64 years of age, Hispanic, Asian or Pacific Islander, and on commercial insurance. And finally, groups that are underrepresented in having a referral resolved compared to having a referral started are younger, Asian or Pacific Islander, and on Medicaid or commercial insurance. And there could be a lot of different reasons why we see these trends. Screening protocols could differ by groups or could differ by area where these different groups are receiving care. Thrive Local could be rolled out to different targeted groups or focused on a different targeted need. The community-based organizations might have different abilities to meet the patient needs. So maybe the patient reaches the CBO, but they're getting resolved differently. And finally, different patient groups might use healthcare differently and therefore might not have the same exposure to Thrive Local in the first place. Sorry about that. There we go. So our takeaways, it's really important to understand how social needs initiatives reach and meet the needs of different demographic groups. We observed group differences in how people progress through the program, and it's important to look at these differences and identify potential systemic issues and areas for implementation improvements. The differences we see could relate to cultural, individual, implementation, and other influences. And, you know, we have the best view of the implementation differences, but we need to consider all of these factors. And finally, focused outreach on populations during the drop-offs identified could improve equitable program implementation and resolution of social needs. And I think I'm at my time, so I'll just say thank you. And here's contact information. Thank you.
Thank you, Rachel. And we'll just go ahead and move on to Cristina.
Thank you. I'll be sharing my screen. And are you able to see my screen okay?
Yep. Yes.
Wonderful. Well, good afternoon, buenas tardes. Thank you everyone for being here today. Thank you to Siren, to our moderator and discussant, and to co-panelists. It is a pleasure to be here with you to discuss our analysis looking at cross-sectional assessment of racial, ethnic, and linguistic equity in social risk screening and results in community health center patients, in collaboration as a partnership of collaborators between Caring Health Center, where I work, Ocean, Siren, Oregon Health and Science University, and Kaiser Permanente. Just a little bit of background about myself coming into this work. I am a social epidemiologist and mixed methodologist. My career has been based in community health centers and community-based organizations, looking at the intersection of health and culture, cultural health beliefs, and translating research into actionable improvements in healthcare practice and policy. We at Caring Health Center, which is a federally qualified health center in Springfield, Massachusetts, are leading the development of FQHC-led research and practice collaboratory. And I collaborate with multiple interprofessional teams with academic, community, and other partners. This particular project is a collaboration between the individuals I mentioned on the title slide. Caring Health Center was established in 1995 and is a Section 330 federally qualified health center. We're the largest refugee health assessment site in Massachusetts, and we serve about 20,000 patients annually, and we serve in over 35 languages. We hire directly from the community many times and partner on research at Caring Health Center for over 2 decades. This is important to the work of this particular analysis because, as I mentioned earlier, we are on a regular basis trying to understand exactly how factors like social care are translated into best practice delivery of service to our diverse patient population. This is an analysis of rates of social risk screening and of reported social risks among community health center patients, many of whom are low income or members of immigrant, refugee, and Black, Indigenous, and people of color or BIPOC communities. Additionally, community health center staff responsible for social risk screening in the health centers that contribute to this analysis are frequently members of the community served. We will report the patterns in the screenings that we've observed, and we would like to discuss some of the implications these patterns may have as they relate to health equity in social. So we were fortunate to partner on data coming from the ASCEND study. ASCEND is a 5-year mixed method step wedge trial that was aiming to address implementing electronic health record, social determinants of health documentation using a step-by-step guidance approach. There's little that's known at this point about social risk screening implementation across racial, ethnic, and language groups. And we're hoping that these analyses and the way that we've examined a large data set in this area can inform us about the associations between race, ethnicity, language, social risk screening, and reported social risks among community health center patients. So these data include patient and encounter level data from 2016 to 2020 across 651 community health centers in 21 states. They come from electronic health record data extracted from a shared EPIC record. And we analyze them using adjusted logistic regression, stratified by language. Social risk screening was our dependent variable, and we looked at social risk screening as a set of variables from the financial resource strain data that are often part of social determinants of health flow sheets or screening tools embedded in the electronic medical record. In this case, this includes variables like child care needs, financial strain, food insecurity, health insurance costs, and so on. Many of you may be familiar with the Prepare tool. There are also other tools that are embedded in the electronic record that collect these data. And they were documented in the EHR. It's important to note that workflows across health centers for collecting social risks differ by health center. And it's also important to know that many health centers at this point have been mandated to collect social risk screening data among all eligible patients annually in response to things like healthcare reform initiatives like Medicaid accountable care organizations and others. This is an example of an EPIC flow sheet for social determinants of health that collects a range of information on SDH. And if you see the circle, the red circle area is highlighting the financial resource strain questions that contribute to these data. So it includes question of how hard is it for you to pay for the very basics like food, housing, heating, medical care, and so on. And it goes through that list of items, food, utilities, transportation, that's in the red circle. Race and ethnicity was the independent variable in this analysis, and it was operationalized with ethnicity as non-Hispanic and Hispanic, and race as Black, white, or other, where other is representing a categorization of multiple other racial categories that had smaller samples. These are also as documented in the EHR, so important to note that they are not always self-reported. So in the data set, we ended up having 1.5 million in total, and of those, 23% were documented as Hispanic, and 77% documented as non-Hispanic. Among the Hispanic, 92% were Hispanic white, were documented as Hispanic white. And among the non-Hispanic patients, 14% were unknown racial category, 17% were non-Hispanic Black, and 39% were non-Hispanic white, and 7% non-Hispanic other race. Some additional patient characteristics included 57% were documented as female, and 43% had a documented cause. Our key findings highlight that among all of those health centers included in the data set, 30% of health centers were conducting social risk screening. And of all the screens, all of the patients who were eligible for screening, which is going back to that 1.5 million, 11% of those eligible adult patients were screened. We found that screening and reported needs varied significantly by race, ethnicity, and language, and I'll go into that in more detail. So on the left here, we have the way in which we can determine how likely someone was to have been screened with the adjusted odds ratios. The middle line where you see the 1 indicates that to the right, they would be more likely to be screened, and to the left, they would be less likely to be screened. And in looking at social risk screening, notably, we found that Black Hispanic and Black non-Hispanic patients were more likely to be screened, ranging from approximately 1.5 to more than 2-fold more likely compared to non-Hispanic whites. Whereas Hispanic white patients in the same table are found to be 28% less likely to be screened compared to non-Hispanic whites. And if you look to the right, among patients who preferred Spanish, we found that patients of other race and Black patients, both Hispanic and non-Hispanic, were between 2 and 3-fold times more likely, and respectively, to be screened compared to non-Hispanic white patients. With regard to social risk factor reporting, again, now looking at that dotted line all the way over to the right, where to the left of it would be just as likely and up, and to the left would be less likely to report. We find that in contrast to being more likely to be screened, Hispanic Black patients were actually 87% less likely to report a social risk, as were Hispanic patients of other race and patients with unknown race. Both were approximately 50% less likely to report social risk factors. And among patients who preferred a language other than English or Spanish, Black Hispanic patients were 90% less likely to report social needs compared to non-Hispanic white patients. So few published studies have actually assessed the denominator of total patients eligible for social risk screening or the characteristics of the patients completing the screening. And our research provides some insights about equity in social risk screening, incorporating both overall patient denominators and race, ethnicity, and language data. Certainly, the results indicate low rates of social risk screening overall and differences in reported risk factors. The assessments of social risk screening and reported risk distributions have been at the health center level. That corresponds to this concept of needing to look at the total eligible and the denominator. Inequitable screening practices could, however, inadvertently undermine the actual goal of social risk screening, which is aimed to address health equity. And we find that it's possible targeted screening aimed at meeting healthcare reform mandates may actually contribute to the screening disparities. Since community health centers and being based in a community health center, CHCs have limited staff and staff face significant competing priorities. This may unintentionally lead to patterns of focusing on patients who are perceived to have the greatest healthcare risks and to focus on those individuals for the purposes of screening. However, this could also unintentionally lead to worsening stigmatization or systematic exclusion of select patient groups. And regarding the lower rates of social risk reporting by REL, during this study period, it's possible that fear associated with the political climate may also have differentially impacted the willingness of some groups to report social risks. We see that language may help to explain differences in screening, and that language can be informative beyond racial ethnic groupings. In particular, this is important for among groups where reporting race and ethnicity as standard categorizations may not be common or representative. It's also an opportunity for us to focus how tailored responses, culturally and linguistically tailored responses, can be done. And so finally, in conclusion, there's a call to action from my co-presenters and myself. We're hearing it in multiple sessions that the need for engagement and additional implementation research to engage community health centers, patients, and community members in determining the best methods for culturally and linguistically responsive social risk screening is critical. Also, clarifying documentation and determining perhaps more granular opportunities for REL data documentation are also needed. And I'd like to thank everyone here today and to Siren for the opportunity to present and acknowledgements to the NIDDK funding and the collaborative partners at each of the partnering organizations, as well as the Advance Network. Thank you.
Thank you for such very thoughtful presentations and on some of the research that you all have been doing. I want to now kind of open it up to Tia. You know, across all three presentations, we did hear, you know, the importance of understanding the social risks and social needs of populations. But we also know that as we're moving toward screening within healthcare delivery organizations, we know that there are racial and ethnic minorities that might not have access to care, and that access doesn't necessarily mean quality care. So Tia, can you tell us a little bit more about your perspectives and lived experiences on this?
Yes, Janet, thank you. And I thank all the presenters, Christine, Dawn, and Rachel for your research and presenting your findings for us. For myself as an expert by experience, as an individual that was diagnosed with HIV in 2001, I did have really good insurance. I had the top notch at age 30, believe it or not. And with that, I had my experience with the better care providers per se in the hospital presented more of stress for me because I was still discriminated against based on my race, I believe, because for them, they kept asking the same question each and every time I saw them, which I was in the hospital for a week and a half. Am I sure that I didn't contract the virus through doing drugs instead of heterosexual contact? So it wasn't until I lost the insurance because I ended up on the long-term care and I had to seek Medicare. And once I went to a public health provider, one that actually cared, that's when things changed for me. She showed interest in my health, and in my care. provided me with her personal number. So it was actually for me, the public and federally funded program that benefited me best, being with a female from Colombia. So still a person of color, Black and brown, that took interest, that was targeted in the area of HIV specifically, that my health took an uptick along with my mindset. So another thing for me that I want to present to you all is mental health something that's considered when you're speaking with someone that's receiving these chronic illness or terminal diagnosis? And because that cannot be determined through those screenings, what a person is like. And then trust, first of all, is the first thing that have to be there between the providers and the support in care with your caregivers. For me, it was my family that was helping. So I had their support at a time where I was weakest. And for my family members, they took off from work FMLA, but they weren't compensated for the time that they took off. So that's another thing that I would like to just throw out there for each of you to consider: the mental health component, the things that we cannot determine through labs as like inflammation, the mental health component, the different things that people cannot see and it cannot be determined through those type of studies. And so the thing is building the relationship and the trust, and also having something in place for those who have caregivers, because taking off of work could be a lot for individuals. My parents did it, but it wasn't like we had something to fall back on, but they did it because they loved me. So to also support the family member of those that's experiencing the illness or disease directly.
Dr. Sanchez, you're muted.
You would think that after all this time you would learn. I just want to say, I know we're running out of time, but if the speakers can just take, 30 seconds to kind of address some of the comments that Tia has made and thinking about the potential unintended consequences of the research that we do in terms of screening for some of these social risks and needs.
Tia, I'm happy to jump in. Oh, go ahead.
No, sorry. Tia, just thank you so much for that. It so resonates with what we're hearing from our community advisory committee, and the importance of emphasizing that relationship, that initial interaction between individuals seeking care and the providers who are working with them. So it's powerful to hear it again affirmed that is such a foundation for not only providing quality health care, but also addressing social needs that are intimately entwined with a person's health and well-being.
Thank you. Yeah, thank you, Tia. I echo what Dr. Wiest said, and I think it just really points to also how medical needs can influence not just that person and their social health needs perhaps, but also those of their family as they take time to care for that person. And that's something that the healthcare system and these screenings won't see. So it's a really good point for us to keep in mind.
And I know that we're really needing to keep an eye on time for the next component of the day. Thank you, Tia, for your contributions. And I just want to acknowledge being based at a community health center, a federally qualified community health center. I think one of the critical components that you're speaking to are members of the care team, including the community health workers and the care coordinators who are members of and representative of the community being served, and who end up being critical agents of both trust building and representation and linkage between the providers and the community and the families, to your point. So I really appreciate your contributions as well.
Thank you everyone for joining us for this session. We encourage you to just join and continue listening on the next session's remarks, but thank you so much for joining us and for such wonderful presentations.